Greetings from Advanced Fertility. Today we are going to discuss a very important topic, PGS, Preimplantation Genetic Screening, which has numerous names over the years. Basically, genetic testing of the embryos. Is it useful? Let's see. Now, over the years, genetic testing of embryos started more than about 2 decades ago. Earlier, they started doing the genetic testing of the day 3 embryo or the cleavage embryo. 10 years later, the Masterbrook study said that it is of no use. And actually, if you're testing these embryos, you are reducing the pregnancy rates. Then this stopped and then came, okay, now let's start testing the blastocyst, which is the day 5 embryos. And many encouraging studies came and people started doing left, right, and center, offering it to patients saying that it is really good and really increases the pregnancy rates. Let's today look a little bit deeper into what this genetic testing of embryos is. Now, earlier, the names of these genetic testing of the embryos, PGS, Preimplantation Genetic Screening. It screens embryos to ensure 23 pairs of chromosomes, 22 autosomes, and the sex chromosomes, and that there is no aneuploidy, means genetic karyotypic anomaly. PGD is diagnosing embryos for known genetic disorders that both the patient and partner are carriers. For example, thalassemia, sickle cell disease, etc. Now, there is no debate in PGD. If there is a genetic disease and there is a risk that the baby will get it, and we can figure out a way to reduce that risk of transmission and to help the couple getting a healthy baby, that is fine. What we are today discussing is genetic screening, is checking these embryos and seeing that there is a normal genetic profile and therefore it has a higher potential to implant. Is this theory true? Is it valid? So over the few years, the PGS has been divided further into, or PGS, PGD, into PGT-A, PGT-SR, and PGT-M. PGT-A is what is aneuploidy. You are checking for the genetic chromosomes, whether there is extra, less. For example, in couples who've had Down syndrome, you can do that. Previous baby with Downs. And then you can similarly with monosomy. So if there are known genetic condition patterns, PGT-A is definitely indicated. Today, we will delve into genetic testing for other than pre-existing genetic conditions. And then is structural rearrangements. For example, you have recurrent IVF failure or recurrent miscarriages, and then you do a genetic testing, and then you find that there is a structural defect in the chromosome. Like there are 22 pairs, each pair has a double chromosome, and then one part of one chromosome is removed and it has gone and attached into another. These are called translocations. So some are balanced, some are unbalanced. So that is to check whether, and this is known to happen in couples with recurrent miscarriages, IVF failures, DiGeorge syndrome, monogenic disorder, means single gene disorders, known inherited conditions, thalassemia, which is quite common in our country. So whether we should be doing the genetic testing, for that, there is no doubt about it. So PGT, SR and M, these are quite strong conditions. Today, we will dwell a lot into PGT-A, which more and more lab doctors are, patients, the internet In fact, there is also a worldwide trend, more so in the US, not so much in Europe. Europe is still going through randomized controlled trials, guidelines. So let's see. So PGT-A claims to reduce implantation failure in IVF and reduce the risk of miscarriage. It is an expensive test. Is it true? And does it really increase the pregnancy outcome? How is it done? This is your blastocyst. So you take out the outer cells. These are the trophoectoderm. These cells become the placenta. And these cells is the inner cell mass. They become the baby later on. So you're not biopsying the inner cell mass. You are biopsying the trophoectoderm. And then you send this biopsy you put it in a container with some special media. Then it goes to the genetic lab for testing. You freeze these embryos in the straw, and then you wait for the genetic testing report, and then you transfer the normal embryos, the normal ones. So some facts about this kind of testing. All cells in any embryo does not demonstrate aneuploidy. There are only small number of cells which show abnormalities. If embryo biopsy shows abnormal DNA, it is not the whole cell that will be abnormal. It is also observed that abnormal cells often self-destruct and some cells self-correct themselves. This self-correction happens more in cells which makes baby than cells which make placenta. For PGT-A, embryo biopsy is taken from trophoectoderm, which is this outer layer. This shows that there is no benefit of doing blastocyst stage embryo biopsy, as cells which are tested are of the outer layer, not the inner layer, which forms the biopsy. Now, this is so logical, this is so clear, yet we have been continuing to do it on the, I will not say pretext, but some studies have certainly shown. So let's just go through a few studies, because for me, this test, I'm not quite sure whether it actually, the normal of the placental cells, is it normal of the inner cell mass? And if it was abnormal, couldn't the inner cell mass autocorrect itself later on? So is the abnormal truly abnormal? Women have transferred abnormal embryos by the test and got normal babies. So now this was a very important study in 2019. It's called the STAR study. And this said that pre-implantation genetic testing for aneuploidy versus morphology. A selection morphology means appearance, regular cell, trophoectoderm pattern, inner cell criteria for single frozen thawed embryo transfer in good prognosis patients. A total of 661 were randomized to PGT-A and morphology. PGT-A did not improve the overall pregnancy outcome as analyzed per embryo transfer or per intention to treat. Now, this is very important. So it did not. Then later on, they wrote another line saying on this subgroup 35 to 40, it did. Now, but it was not significant when analyzed by intention to treat. So what is intention to treat? Intention to treat means there are two arms. In one, you started with egg collection. You have offered PGT-A. In this, you started with egg collection. You did not offer PGT-A. In this, you reached to blastocyst. In this, you reached to blastocyst. So in this, only the normal embryos results you are comparing. Okay. So what about all the abnormal embryos? 3-4 embryos normal, 4-5 embryos abnormal, and 3-4 may 2 or 3 got pregnant. So 60% pregnancy rate for this group of embryos. But what about the total number of eggs that were given? So for example, this actually 2 out of 4 or 3 out of 4 for 7 embryos. So it's actually 3 out of 7. On the other hand, when you did not do PGT-A, you transferred each embryo, 7 of them, and 4 got pregnant. So out of the healthy embryo, 3 out of 4, 65, 75. But out of all of them, 3 out of 7. Here, 4 out of 7. So which had more pregnancy? This 3 out of 4 or this 4 out of 7? So I know it's difficult to understand, but intention to treat, you have to start from per egg collection, not per normal embryo. Because if you get 4 blastocysts, all are good, most will implant. But suppose you did not get the normal, you transferred them earlier, you'll get more pregnancies. Let's see if I can make it clearer. So again, Dr. Gleischer, he is in the US, and he has always spoken against systems that are not technically proven. So this was a STAR study, which I discussed earlier. And then there was this another study by Kang et al. Kang et al. Was in Japan, which reported seemingly improved live birth rates following PGT-A, but outcome advantage actually reversed itself after correct intention to treat analysis outcomes with reference start cycle. Pregnancy as well as live birth rates indeed ended up to be significant higher in non-PGT-A patients. Considering all presented evidence, it is difficult to understand what further argument can be made for the continuous routine clinical utilization of PGT-A to improve IVF outcomes. IVF outcome failure, do PGT-A. Transfer good embryos. Really, there's no scientific basis to that. Now, what is again the study for PGT-A? Any new thing in market, whenever it comes, unfortunately, without standing the robust test, it is propagated. Now, for example, you have 10 eggs, 47% blastulation, means 5 blastocysts. Aneuploidy rate 59%, means when you do biopsy, few of the biopsy will be abnormal. So then some are mosaic, means some cells will have half gene of the parent, half gene of the mother, father, mixed chromosomes. You have to discard those embryos. Maybe they would have auto-corrected later. Technical errors. Doing a biopsy is a technically challenging job. You know, you might destroy embryos. You may not be able to pick up the right cells. Your testing may have a defect. Your carriage of the cells, then it going to the lab and getting reported. All these things, there are multiple human and scientific factors that are important in genetic testing of embryos. And therefore, so suppose you take 10 eggs and you see ki so many embryos have blastulated, this many have mosaic, this many have technical errors. And they studied it in PGS, non-PGS, clearly demonstrated the superiority of non-PGS embryo, both day 3 and blastocyst, over PGS blastocyst transfer. Another study. So here we did not do PGS. There were 10 eggs and there was 2 were positive, 2 were negative. Okay. So here you will say there were 4 blastocysts, okay, and we transferred all of them, 2 positive, 2 negative. So you will say 50%. But here only 2 transferred, you will say 100%. So you've done an extra cost test you've included more personnel, more laboratory, more treatment time, more waiting time, and you've got only 2 people pregnant. 2 plus got pregnant in both the stages. Here, you invested more time, more technology, cost. Here, you just transferred all of them and you got 2 right. So, we have to see, we have to analyze data and what is being said about scientific papers in criticality. So Cochrane is one of the most important scientific forum which analyzes huge amounts of data and then tells us whether a certain process is beneficial or not beneficial. So in 2020, there's insufficient good quality evidence of a difference in cumulative live birth after first embryo, or miscarriage rate between IVF with or without PGT-A. The current available evidence is insufficient to support PGT-A in routine clinical practice. So, what have we seen so far? In the embryo, errors may occur during genetic analysis of small amount of DNA calculated. You're taking out a small piece of the cell and you are, based on the analysis of that cell, you are identifying whether there is a problem in the whole embryo vis-a-vis the future baby. So there may be errors. You have to put it in a media, you have to take out genetic material. These are all systems, right? Then there might be mosaic. These cells, the cells that you take out may show different patterns and they are in the early stages of embryo formation. So this mosaicism is very high. Half of one chromosome, half of one parent. Some normal embryos will be discarded. They would have auto-corrected, leading to an overall decrease in cumulative pregnancy rate, which was achievable by the eventual transfer of all embryos in the cohort. In this data, I tried to show you that only 2 got pregnant, okay? But suppose another one got pregnant, 3 out of 4. This would have been, instead of 50%, 75%, whereas those 2 would have been discarded. Okay. So, real possibility of damage to the blastocyst. This is an American study. And no studies have addressed the impact of trophoectoderm biopsy in embryos with less than ideal morphological characteristics in older patients after an intervening cryopreservation. So sometimes you freeze the embryo and then you do the biopsy. What is the effect of that? What happens to the trophoectoderm, etc.? Those studies are also not there. Then this was a UK study saying that it really increases the cost of IVF treatment. Anyway, at least in India, it is not funded. Couples are paying out of pocket. IVF is not 100% successful. Many times you have to do 1, 2, 3 attempts. So rather than offering these techniques, which according to me, they may be great over a course of time, we may be proven wrong. But the current evidence is not strong. It is very good for genetic problems, previous known karyotypic anomaly, all that it is good. But for miscarriages, IVF failure, how much it really helps, the data is still not there. The technology is still not substantially logical to substantiate it and give it and offer it to our patients on a routine basis, stating that it is going to improve our results. It can be offered on an experimental basis. That has to be made very clear and consent needs to be taken. So, on conclusion, we can say that any intervention that claims to increase the pregnancy rate in IVF must stand the test of time. Till then, it must be clearly offered as an experimental test and at least should not financially drain the patient. So thank you very much. I look forward to your comments and questions. And till we meet next, have a great day. Goodbye.